Welcome to the Deep Dive. Today we are strapping in for what is, I think, arguably the most foundational, critical, and, well, challenging field in acute care medicine: trauma.
It absolutely is.
When you have one of these severe energy transfer events, a high-speed collision, a fall, a penetrating injury, knowing where to even start and, crucially, what to prioritize is literally the difference between life and death.
It truly is a race against time, and that is exactly why we're going to take a structured, deep breath and just plunge into the core principles. We're looking at Chapter 26 of the 28th edition of Baily and Love.
Yeah, this is the bedrock.
It is. And we're focusing specifically on Introduction to Trauma Management.
Okay, so our mission today is very specific. We're tailoring this for those of you who are, absorbing this dense material right now. We're going to try and interpret and structure these complex, high-stakes concepts.
We want to give you some mental anchors, some practical metaphors, and really dig into the clinical rationale behind the protocols.
Think of this deep dive as your focused, high-yield ready reckoner. It's a scaffold for your revision, designed to make things stick. But we have to be absolutely clear here.
Yes, this is our interpretation and our analysis. It is not, and I repeat, not a substitution for reading the full textbook. You have to do the reading.
Of course. Our goal is to move past simple memorization and get to the fundamental logic. So the core question that really underpins this whole dive isn't about mastering the steps of one procedure.
No, it's about understanding the structure and the priority of trauma management itself. Why is the sequence of action, that absolute mandate of what to do first, just as important as, say, your technical proficiency?
Because the answer is simple, and it's ruthless, and it governs every single decision.
Time.
Time, and the immediate need to prioritize what kills the patient first. Everything, and I mean everything we discussed today, flows directly from that life or death timeline.
Exactly. So let's get started.
Okay, let's unpack this concept of injury. I want to start with a real foundational definition. What specifically is trauma in a formal medical context?
Well, formally, trauma is defined as an injury that results from an energy transfer from some kind of inflicting source.
An inflicting source. So what kind of energy are we talking about?
It can manifest in several ways. It might be chemical, thermal, maybe ionizing radiation, but most commonly, the one we see every day, is mechanical energy.
And the severity of the injury just depends on how much energy for how long.
Precisely. It's a direct function of the magnitude, the specific nature, and the duration of that inflicting energy.
So we're talking about a whole spectrum here, from a minor sprain all the way up to catastrophic multi-system failure. So how do clinicians then distinguish between a routine injury and what we call major trauma?
Yeah, what separates the walking wounded from the critically ill, right?
Exactly.
Major trauma is clinically defined by the scope of the damage, so injuries to more than one body region or organ system. But, just relying on a subjective assessment isn't really enough.
No, especially not in a high-pressure environment like the trauma bay. You need something objective.
You need objective, quantifiable data.
Okay, so this brings us to our first really critical anchor concept for this kind of assessment: the Injury Severity Score, or ISS.
Exactly. The ISS is the crucial tool for stratifying the severity anatomically. It's calculated using something called the Abbreviated Injury Scale, or AIS.
Okay, so what's the AIS?
The AIS is basically a consensus-derived threat list. It assigns a severity score. It ranges from 1, which is mild, all the way up to 6, which is maximum or, frankly, unsurvivable, to over 2,000 specific injury codes.
Wow.
Yeah, so think of it as a dictionary of injury severity.
So how does the ISS score then condense all of those individual injuries from that dictionary into one number?
Right, so it's not just a simple addition of scores. It's a bit more clever than that. It's a summation of the squares of the highest AI scores in the 3 most severely injured body regions.
The square, so it weights the worst injuries more heavily.
It does. So, for example, if a patient has a severe chest injury, that's an AIS of 4, and a moderate head injury, an AIS of 3, and maybe a moderate limb injury, also an AIS of 3, the ISS would be 4 squared plus 3 squared plus 3 squared.
So that's 16 plus 9 plus 9, which gives you an ISS of 34.
Exactly.
That seems a bit complex, but I guess it forces you to focus on the body systems that are most threatened. So what's the magical number? What defines major trauma?
The key number you really need to anchor in your mind is this. Major trauma is defined as an ISS greater than 15.
Over 15.
Anything above 15 signifies a high mortality risk and usually requires the resources of a dedicated trauma center. But, and this is vital, you have to recognize the limitations of the ISS.
Really?
It's purely anatomical. It tells you where the damage is, but it tells you nothing about the patient's physiological ability to cope with it.
Ah, okay.
So a 70-year-old with pre-existing heart disease and an ISS of 16 is much, much sicker than a healthy 20-year-old with the exact same score.
That distinction between the anatomical score and the physiological reserve is absolutely key. But let's look at the sheer numbers. It sounds like major trauma cases are rare, yet we dedicate immense resources to them.
They are rare in quantity, but they're massive in their impact. The vast majority of patients admitted with an injury, maybe 85% of them, have low ISS values, between 4 and 9, an isolated fracture, a mild concussion.
Right, the day-to-day stuff.
But that remaining 15%, those with an ISS over 15, they consume a completely disproportionate amount of hospital resources, staff time, and specialist expertise.
And this brings us to the global burden. The term modern epidemic gets thrown around a lot.
And it is entirely appropriate. Trauma, globally, accounts for the largest number of deaths and disability in children and young adults in industrialized nations.
We're talking about the loss of young, productive years of life.
Exactly. And that has massive socioeconomic ripple effects.
And the raw figures are just staggering. The World Health Organization estimates something like 5 million injury fatalities worldwide every year.
Yeah, and that 5 million represents about 9% of all global deaths. But to put that in a really devastating context, the source material notes that this rate is 1.7 times higher than the combined deaths from malaria, tuberculosis, and HIV/AIDS.
Wow. That is an incredible statistic.
It is. When you think about the huge global health focus on those infectious diseases, the sort of silent devastation caused by trauma is just profound.
So what are the main drivers of this crisis?
A striking 64% of these fatalities are attributed to just 3 prevalent causes: road traffic accidents, or RTAs, falls, and intentional violence. And RTAs are particularly dominant. They represent a massive public health failure on a global scale.
And while you might associate trauma with wealthy, industrialized nations, high-speed travel and construction, the geographical trend is actually really alarming.
It is. The major burden is rapidly shifting and increasing in low and middle-income countries.
And why is that?
It's a direct consequence of rapid industrialization and the corresponding surge in motorized transport. But often it's happening without the necessary infrastructure or the robust safety regulations that you'd find in high-income nations. And that fundamentally alters where public health resources need to be directed globally.
So moving from the young victims of high-energy transfer, we also have to address this very vulnerable and distinct population. Older adults. They're living longer, but their injuries carry this unique and increasing burden.
Absolutely. While high-energy multiple injuries affect the young, older adults are increasingly affected by low-energy mechanisms, which lead to what we call fragility fractures.
And this represents a huge future burden on healthcare systems.
A massive burden, because these patients aren't just fixed and discharged. They often have incredibly complex long-term rehabilitation needs.
Can you anchor that with a specific example for us?
Sure, let's look at the data for proximal femoral fractures, what people commonly call a hip fracture. In the UK, we see around 70,000 admissions per year for this injury alone.
70,000.
And for those over 65, the 30-day mortality rate is alarmingly high at 6.7%. And that's not just due to the broken bone.
No, it's the systemic stress on an already frail system.
Exactly. It's the physiological stress that fracture imposes on a system with very little reserve.
And even the people who survive suffer this significant loss of functional capacity.
Precisely. They experience a profound loss of independence. Their trauma wasn't caused by massive energy, but by insufficient energy acting on compromised bone stock. The clinical vigilance required for this group is very different from what's needed for a young polytrauma patient.
Okay, so to synthesize this initial information, we're looking at an epidemic driven by high-energy transfer in the young, but also this rapidly growing crisis of fragility fractures in the old.
That's the key takeaway. The clinician on the floor has to keep 2 things in mind. First, severe trauma is the major killer of the young, and it demands immediate aggressive intervention. And at the same time, you have to be exquisitely vigilant for the older patient cohort, where a seemingly minor mechanism can hide devastating systemic consequences. And, critically, always maintain vigilance for occult issues like pathological fractures or terrifyingly non-accidental injury in children.
So early detection is everything.
Early detection is paramount.
That gives us a really solid foundation on the scale and the shape of the problem.
Indeed. We know the enemy and its scope. Now we need the battle plan.
Right. We established that time is the critical factor. Let's delve into the actual timeline. We define time point zero as the seconds before the event, when the patient is at their baseline. What happens immediately after that point?
Everything. Absolutely everything. Every subsequent process, the body's physiological response, its attempt at compensation, eventual healing, and of course our medical intervention. It's all governed by this unyielding timeline. This is the timeline principle.
And the core idea here is that there's an optimal time window for a successful intervention. I really like the metaphor anchor we discussed earlier for this.
Yes, let's use that. Compare the trauma timeline to a ticking clock in an escape room. The injury has started a countdown. You, the clinician, you have limited time before irreversible damage or death occurs.
So you can't just leisurely explore every room.
No, you have to identify the most dangerous puzzles, the life threats, and solve them immediately. If that clock runs out, the game is over, regardless of your ultimate technical skill.
And this principle translates directly into the central mantra of trauma care. What kills first gets managed first. It forces immediate identification and treatment of these rapidly evolving catastrophic situations.
And we are talking about conditions that can lead to death within minutes. Airway obstruction, a major tension hemothorax, hemopericardium leading to cardiac tamponade, and of course, uncontrolled intra-abdominal bleeding.
These aren't conditions you observe.
No, these are conditions you diagnose and treat almost simultaneously.
And the time taken for an effective intervention is the sum of two factors, right? Assessment time and response time.
Yes, and both of those components have to fit entirely within that pre-death window. If you spend too long assessing, the window closes. If your response is too slow, the window closes.
The clinical framework that really formalizes this time dependence principle is, of course, the Advanced Trauma Life Support System, or ATLS.
Right. It provides a very strict hierarchical approach. Airway, A, breathing, B, circulation, C, disability, D for neurology, and then exposure environment, E.
And for those of you in your studies, this is a huge shift in thinking. Unlike routine medical practice during that ATLS primary survey, you are actively omitting normal history taking and extensive physical exams. Why is that?
Because they take too long. A standard history and a detailed physical examination might take 20 minutes. If the patient has an airway obstruction, they are dead in 3 minutes.
It's that simple.
The primary survey is ruthlessly efficient. Detection, ranking, and efficient treatment of immediate life threats, according to that strict ABCD hierarchy. You must manage a life threat before you even think about moving to the next letter.
And we have to emphasize the proactive nature of this. You can't just wait for the overt signs of deterioration.
No, absolutely not. The problem is that the physiological system is highly compensatory. The body is designed to hide catastrophic internal damage, especially bleeding, until it can no longer cope.
So waiting for the blood pressure to drop.
Waiting for the blood pressure to drop significantly often means the patient has already lost 30 to 40% of their circulating volume and is entering irreversible shock. You've missed the boat.
Let's use a fictional case study to illustrate this danger of waiting. Imagine a patient involved in a high-speed RTA presents with a superficial scalp laceration and a reduced Glasgow Coma Scale, a GCS score of 13 out of 15.
Okay, so that GCS drop is concerning. It could be systemic, so shock or hypoxia, or it could be localized to the head. The hidden threat we are really worried about here is the classic rapidly evolving intracranial hemorrhage, like an extradural hematoma.
And the source material illustrates the timeline for an extradural hematoma so vividly. Often these patients have that brief lucid interval and then they deteriorate incredibly quickly.
They do. And if we wait for the major undeniable drop in GCS, say below 8, when the patient needs immediate intubation, we've already missed that optimal time window.
Because the hematoma has already expanded.
It's expanded, it's causing brainstem compression and potentially irreversible damage.
So that's the key clinical insight then.
It is. A prompt head CT diagnoses that hematoma before the critical late clinical signs develop. If we intervene surgically with a craniotomy when the patient is GCS 13, their chances of a full recovery are infinitely higher than intervening when they're GCS 5 and already herniating.
So this really demonstrates the necessity of introducing a management response present, proactive imaging, getting the surgical team activated immediately, even before the definitive clinical presentation occurs, because just relying on those overt signs would be fatal.
It shifts the trauma surgeon's role from reactive to predictive and proactive.
Yeah.
You're anticipating the next threat on that timeline.
Okay, let's pause for a moment here for a check-in question. Thinking about our RTA case study, the patient with a GCS of 13, If that GCS drop was not due to an epidural hematoma, but was instead due to systemic shock from hidden internal bleeding, which priority in the ABCD sequence would you address immediately, and why?
The immediate priority has to be circulation, C, followed very closely by breathing.
Yeah.
Systemic shock and severe hypoxia affect the brain far faster than localized compression.
Right.
Rapid restoration of perfusion, so stopping the bleeding and ensuring adequate oxygenation, are fundamentally life-saving. If you hesitated on that, pause and think about why C takes precedence over D, disability, in the primary survey. And if you need to, rewind and review that ABCD sequence again.
The ultimate success of this aggressive timeline management relies entirely on resources and system structure. This is why the source material emphasizes the absolute need for a dedicated multidisciplinary trauma team and a CT scanner that is available 24/7.
And that's the whole rationale for regionalization, the designation of Level I trauma centers. These centers possess the necessary high acuity structure, the staff, and immediate access to specialists like vascular, neurosurgery, orthopedics that you need to effectively beat that ticking clock. A unified system just reduces handovers and delays.
And crucially, this dynamic timeline applies not only to the immediate resuscitation phase, but to the entire patient journey.
That's a great point. A secondary assessment is needed after stabilization, and then a tertiary assessment, often 24 hours later, is necessary to catch subtle or missed injuries. The job is never truly done until the patient is definitively treated or discharged.
So key takeaways for the timeline. Time is the enemy. The goal is for assessment and response to happen before irreversible damage. The ATLS ABCD protocol is the practical, non-negotiable application of that what kills first rule. And trauma management is a dynamic, continuous process. Stabilization is just the beginning.
Well said.
Okay, so we've managed the immediate life threats, and we've bought the patient some time. The next challenge is the accurate, comprehensive assessment of all the injuries. We're transitioning from urgency to focused clinical analysis.
This is where we bring back our guiding formula anchor, which is really the cornerstone of clinical thinking in trauma. Mechanism plus patient factors, if wills. Injury sustained.
Right.
The clinician's task is to act like a detective, synthesizing the energy transfer, the mechanism, with the characteristics of the patient to predict the potential damage.
And the real power of this formula is its predictive capacity. It directs your attention to areas that may not show obvious damage. But if the pieces just don't add up, if the severity of the injury seems inconsistent with the reported mechanism, that should immediately trigger a high index of suspicion.
That inconsistency is the warning signal. It points toward either hidden pathology, so an underlying disease making the patient vulnerable, or deliberate concealment, which sadly we do see in things like non-accidental injuries.
Let's break down the mechanism classification, starting with blunt trauma, which is the most common, RTAs, falls. We divide this into direct and indirect forces.
Direct blunt trauma is the simplest to understand. The damage is localized precisely to the site of force application. A hammer blow to the shin causes a fracture directly under the point of impact.
But indirect blunt trauma is far more dangerous because the injury is remote from the impact site. Our classic example anchor here is the car collision.
Yes. The driver's knee hits the dashboard, that's the initial impact point, but the force is transmitted up the femur, leading to an acetabular or a hip joint fracture dislocation. The clinician has to look along that entire vector of force transmission.
And we have to talk about the insidious nature of that transmitted force, especially through fluid-filled compartments.
Yes, a sudden, crushing force applied to the lower abdomen can create a pressure wave that travels through the soft tissues and the vascular tree. This can lead to non-obvious, potentially catastrophic injuries, like an aortic rupture or unexpected vascular hemorrhage remote from the initial impact.
So the external bruising might be minimal.
Minimal, but the internal damage is devastating.
Okay, next, penetrating injuries. For sharp objects knives, broken glass, the key information you need is the length of the weapon, the surface area of the blade, and the size of the entry point. This helps you predict the depth and the path.
And the clinical danger lies in the unpredictable path of that object, especially across body cavities. This requires our vital anatomical alert for the torso.
Which is?
Clinicians must remember that abdominal structures extend far higher into the chest cavity than many realize, potentially up to the level of the fifth rib in deep expiration.
So a wound that looks like a low chest injury
Can easily involve the spleen, the liver, or even the stomach, requiring a laparotomy, not just a simple chest drain.
And for penetrating injuries from firearms, we differentiate between low velocity, like a pistol shot, which has similar damage to a knife, and high velocity projectiles, typically from military or hunting rifles.
High-velocity projectiles create extensive damage far beyond the bullet track, and that's due to the rapid transfer of kinetic energy. This leads to the concept of temporary cavitation.
Temporary cavitation is terrifying. The energy transfer creates this enormous pressure wave, accelerating the surrounding tissue laterally. This cavity is short-lived, it only lasts for milliseconds, and then often closes up, leaving a deceptively small entry and exit wound.
And the clinical importance is immense. Because that tissue has been violently stretched and compressed, the surgeon must perform a wide wound exploration and meticulous debridement.
Why?
Because foreign material, clothing, bacteria can all be sucked deep into the wound track by the vacuum created when that cavity collapses. Failure to explore that adequately leads to deep infection, necrosis, and chronic complications.
Okay, so now we incorporate the patient factors. Age, comorbidities, body habitus, they all dictate injury patterns. For instance, a child struck by a car suffers different lower body injuries than an adult because of the relative difference in their center of gravity.
And we use obvious injuries, the ones found during the E for exposure in ATLS, as clues. Scrotal bruising in a motorcyclist strongly suggests a concomitant pelvic fracture, which signals potential massive volume loss.
Or the seatbelt sign.
A seatbelt mark across the abdomen, the seatbelt sign, is not just a bruise. It suggests massive internal damage to the bowel or the mesentery, demanding immediate investigation. You have to expose the patient fully to see these vital signs.
But the real clinical challenge, as we noted, is when that trauma equation fails because of hidden factors.
And we deal with two major types of hidden factors. The first is hidden mechanisms or deception. A patient may fabricate a history due to fear, criminal involvement, or abuse.
Let's look at the case study from the source, the misleading fall. A patient presents with a painful calcaneal fracture, a fracture of the heel bone. He reports falling into a pothole.
Right. But clinically, you know that calcaneal fractures are highly associated with falls from a significant height, like a jump or fall from 10 meters. If the clinician just accepts the minor pothole story, they might miss the associated injuries that often occur when falling from height.
Like a lumbar spine fracture.
Exactly, because they didn't look for it. The clinical imperative is that while you must treat the patient with respect and let them tell their story, you have to critically evaluate the findings against that reported mechanism. Inconsistency raises a red flag, and that flag means deeper investigation is required regardless of the patient's narrative.
And of course, the most critical application of this suspicion is in protecting vulnerable populations. We have to anchor the critical flags for non-accidental injury, NAI.
Yes. External signs inconsistent with the reported mechanism, multiple injuries in different stages of healing, or suspicious patterns like posterior rib fractures or long bone fractures in preambulatory children. Suspicion demands immediate action.
The second hidden factor is hidden patient pathology. This is when a low-energy mechanism causes a severe injury. The body itself is the weakness.
So this means pathological fractures due to underlying diseases, metastatic tumors, severe osteoporosis, or congenital bone diseases like osteogenesis imperfecta brittle bone disease.
And if you miss the underlying tumor.
You not only manage the fracture incorrectly, but you delay life-saving cancer treatment.
And also, the injury might be the result of a medical event, not the cause.
That's a huge point. A patient falls and breaks their wrist. Was the fall a mechanical slip, or did it result from a transient ischemic attack, TIA, an epileptic seizure, or a serious cardiac arrhythmia?
So you treat the fracture, but if you miss the underlying medical pathology, that patient is going to come back next week with another, perhaps fatal event.
Exactly. The secondary survey must thoroughly explore those medical comorbidities.
So after this comprehensive analysis, how do we systematically ensure we haven't missed anything?
We use two defined approaches. First is the look everywhere approach. This is the detailed secondary and tertiary survey. This approach has been completely revolutionized by technology, specifically the implementation of whole-body CT, WBCT, in major trauma centers.
WBCT accelerates diagnosis by picking up injuries, especially in the spine, pelvis, and abdomen. That would be missed by initial x-rays. It saves precious time. But we have to address the significant concern raised in the source material, the risk of radiation exposure.
This is a critical ethical and clinical balancing act. A single full-body CT delivers an effective radiation dose of about 12 to 16 millisieverts. To anchor that number for you, it's the equivalent dose of 76 chest radiographs.
76, that's a profound dose. How do centers justify it?
They justify it because the benefit rapidly finding a life-threatening occult injury outweighs the modest theoretical long-term risk of cancer associated with that dose, which is estimated at around 1 in 1250. But the source material explicitly warns against the widespread and uncritical use of CT, which contributes significantly to population radiation exposure. The key is appropriate triage. WBCT is generally reserved for patients with severe physiological derangement or high ISS scores, where the risk of a missed injury is highest.
And the second approach is the focused exclusion approach.
This relies on clinical experience, which shows that certain specific injuries are notoriously missed in the initial chaos. The clinician has to maintain a high index of suspicion for the common culprits.
Now, what are they?
Metacarpal and metatarsal fractures, often dismissed as simple hand or foot sprains, scaphoid fractures in the wrist, which have a high risk of a vascular necrosis if missed, and in the shoulder, posterior shoulder dislocations.
Okay.
If the mechanism suggests one of these, you must specifically investigate them, often with specialized views or additional imaging, to definitively rule them out.
So to wrap up assessment, key takeaways. The formula, mechanism plus patient injury, must always be tested against the findings. Inconsistency demands investigation. Be hyper-aware of indirect forces and temporary cavitation. WBCT is fast, but carries radiation risks. Use it wisely. And systematically exclude those commonly missed injuries.
Perfect.
Okay, so we've established the full extent of the trauma. Now we execute the clinical response. This is the physiological battleground where the patient's body is fighting against the injury.
Right. The patient's immediate physiological response is to try and maintain homeostasis, but the injury triggers a massive systemic immune inflammatory acute phase response. People often call it the cytokine storm.
So our initial treatment goals have to counteract the lethal triad of trauma.
Hypothermia, acidosis, and coagulopathy. Yes. We must reverse hemodynamic instability, which means stopping ongoing bleeding, preventing that spiral into clotting failure, and ensuring no secondary damage from hypoxia.
And maintaining core temperature is non-negotiable.
It is. Hypothermia, which is often exacerbated by exposure, IV fluids, and massive blood loss, severely impedes the clotting cascade. Simple measures, warming the patient using blood warmers, are crucial safety measures that prevent the patient from progressing into that lethal triad.
Now, resuscitation guidance has seen a dramatic shift over the last decade or so. The old approach involved infusing huge volumes of simple crystalloid solutions. That has been replaced by a much more nuanced approach.
Absolutely. The current guidance advocates for reduced crystalloid administration and the early transfusion of blood products in a balanced ratio, often 1.1.1, so plasma, platelets, and red cells. We need to stop that old practice of just giving liters of saline before blood arrives.
Why did we shift away from aggressive crystalloid use? What was the harm?
Over-resuscitation with crystalloids leads to several catastrophic problems. First, you get dilutional coagulopathy. You're just diluting the patient's remaining clotting factors and platelets, pushing them into uncontrolled bleeding. Second, it exacerbates tissue edema, causing third spacing and potentially leading to organ dysfunction, including acute respiratory distress syndrome, ARDS, and increased intracranial pressure.
And abdominal trauma.
It can lead to abdominal compartment syndrome, ACS, which restricts breathing and circulation. We learned that massive crystalloid infusion often just makes the patient sicker.
Now, the trauma bay is an environment of coordinated action, activated by ATLS. Who is the critical orchestrator in this environment?
The team leader. Their role is paramount. They coordinate personnel, they allocate resources, they ensure the ATLS checklist is followed, and critically, they are the single point of decision authority which allows them to override standard protocols if a delay is identified.
They're the communication hub.
They are. They prevent delays and diffusion of responsibility.
And standardization helps everyone move efficiently. Let's mention the role of national protocols.
Documents like the NICE guidelines for major trauma and specific specialty protocols like BOAST from the British Orthopedic Association are essential. They standardize care across different hospitals, reduce the chance of human error, and they provide a strong medical legal basis for decision-making under extreme pressure.
We discussed the danger of mislabeling earlier, particularly in the elderly population. Let's circle back to that specific case study of the elderly fall.
Right. The 80-year-old patient who falls, fractures a wrist, and is just labeled as a simple accidental fall. The first clinician's decision to accept that simple label risks missing the severe underlying pathology that caused the fall.
So, occult heart failure, a drug interaction, a TIA.
A new diagnosis of epilepsy. Anything.
Hmm.
The source material stresses that the first clinician in the diagnostic chain has a disproportionate responsibility. If you inappropriately label the condition as simple trauma, that patient gets shunted down the wrong care pathway, often bypassing the senior medical review they desperately need until they rapidly deteriorate.
So appropriate physiological triage and senior consultation are the only safeguards against this fatal error.
That's it. Now, moving beyond the initial resuscitation, we arrive at the major strategic decision point for the polytrauma patient: the timing of definitive surgery. This involves the conflict between early total care (ETC) and damage control orthopedics (DCO).
And this strategic choice is driven by the profound understanding of the first hit, second hit theory. Can you explain that core concept?
The first hit is the initial injury, the massive physical trauma. This induces a systemic, often uncontrolled inflammatory response. The patient's body is primed.
And the second hit is the major, often long, definitive surgical intervention, the process of fixing all the injuries.
Right, and if the patient is already physiologically exhausted by that first hit, introducing the second hit, the massive stress of an operation, can be the final blow.
It just exhausts their biological reserve.
It does. It pushes them into multi-system failure. Adult respiratory distress syndrome, ARDS, where the lungs fail due to severe inflammation and fluid accumulation, and multiple organ dysfunction syndrome, MODS, where failure progresses beyond the lungs to the kidneys, liver, and brain. The surgery intended to fix them actually kills them.
Historically, early total care, ETC, fixing all fractures early, usually within the first 24 hours, was the gold standard. And it still is for the vast majority, about 80 to 90%, of stable polytrauma patients.
But for those critically unstable patients, those with ongoing shock, severe head injuries, or massive chest trauma (ETC) proved fatal. This led to the adoption of the damage control orthopedics (DCO) philosophy.
And DCO is essentially surgical triage. It's temporary, life-saving surgery. What are the key stages?
The stages are simple and fast: resuscitation, hemorrhage control, decompression like a fasciotomy, decontamination, and, critically for orthopedics, fracture splintage using rapid temporary devices like external fixators. Definitive fixation is explicitly delayed for 4 or more days until the patient's physiological state has normalized.
So the surgeon has to be able to make that switch under pressure. Let's present the check-in question that defines this switch. What specific physiological criteria dictate the decision to step back and adopt DCO instead of ETC?
The answer lies in the objective markers that signal the body's reserve is exhausted. The criteria for damage control surgery include markers of that lethal triad: hypothermia below 34 degrees C, severe acidosis, a pH less than 7.2, and signs of massive hemorrhage and shock.
Look, right.
A serum lactate over 5 millimole, an ISS greater than 36, blood pressure under 70 mmHg, or a transfusion requirement approaching 15 units. If the patient meets these objective criteria, the surgeon must choose stabilization over definitive repair.
Why are those specific numbers so important? For example, why is a pH below 7.2 so significant?
Below a pH of 7.2, the enzyme systems that are critical for clotting and cell functions simply shut down. The entire body's metabolism fails. The high lactate is a marker of profound tissue hypoxia, meaning the patient is operating anaerobically. It's a signal of severe shock that has to be corrected medically before any major stress-inducing surgical endeavor.
And this really highlights the shift toward individualized care, moving beyond ETC and DCO as these rigid binaries.
Precisely. Newer philosophies like early appropriate care and the PRISM concept prompt individualized safe management, emphasize tailoring treatment to the specific patient's genetics, comorbidities, and physiological trajectory. The guiding principle is to do no further harm by avoiding that second hit rather than just fixing everything immediately.
Which demands sophisticated contingency planning.
Every surgical plan must include a defined Plan B. If you start an ETC procedure, say intramedullary nailing of a femoral fracture, and the patient rapidly deteriorates intraoperatively, the lactate is rising, pH is falling, temperature is dropping.
That team has to switch.
The team must be immediately ready to switch to DCO. That means abandoning the definitive procedure, quickly applying an external fixator for temporary stabilization, and returning the patient to the ICU for continued resuscitation. That quick switch saves lives.
So, key takeaways for response strategy. The initial response must target the lethal triad, relying on early blood products over excessive crystalloids. ETC is standard for stable patients. DCO is mandatory for unstable patients to avoid the catastrophic second hit. And the decision to switch is based on specific, objective physiological criteria.
You've got it.
We have managed the immediate crisis and determined the macrosurgical strategy. Now let's zoom in on the detailed planning required for successful outcomes and the long view of injury prevention.
Right. In a critically ill patient, the opportunity to intervene successfully is precious, and it's often singular. So adequate preoperative planning is crucial to eliminating unnecessary delays and avoiding catastrophic errors. It requires a deep dive into every possible detail.
And this involves meticulous analysis not just of the injury, the fracture pattern, the soft tissue state, but also the patient's overall physiological status, including their biochemical markers.
And the plan has to detail the exact patient positioning, the precise surgical approach, the implant type, and even the contingency for soft tissue complications.
This is why we rely on that ultimate contingency planning anchor, the necessity of developing Plan A, Plan B, and Plan C.
A trauma surgeon has to constantly assess, is the patient physiologically optimized? Is the timing truly optimum? Or could waiting a few hours for better coagulation results improve the outcome? And critically, if Plan A, the preferred definitive surgery, fails, what equipment and what surgical approach will constitute Plan B and Plan C?
And this detailed plan has to be communicated across the entire operating room team.
Absolutely. The source material advocates for documenting the plan often prominently displayed on a whiteboard. This simple act ensures that every member, surgical and anesthetic, understands the primary path, the potential intraoperative complications, and the agreed-upon alternative pathways. No confusion, no delays.
Beyond individual operations, systematic care relies on unified protocols.
Local and national protocols for things like mass transfusions, spinal clearance pathways, or the use of angiographic embolization for severe pelvic fractures are indispensable. They facilitate swift, standardized decision-making under duress and provide robust medical legal protection, ensuring all patients receive a minimum standard of care.
And an often overlooked function of systematic care is the observation of clinical trends. This is where that timeline concept extends far beyond the first hour.
Correct. Standardized local policies require continuous daily input of physiological metrics, vital signs, biochemical results like lactate clearance and base excess, and oxygenation levels. The absolute value of lactate is important, but the trend is the lactate clearing over time is a powerful indicator of successful resuscitation.
So why is tracking the trends so crucial?
Because observing a negative trend allows clinicians to identify an evolving clinical condition, like the development of systemic sepsis or a pulmonary embolism, at a very early stage. This enables intervention within the timeline concept before irreversible damage occurs.
So if a patient's oxygen saturation trend is slowly declining over 12 hours,
that is far more actionable than waiting for overt respiratory failure. Early identification allows for early intervention, and that often results in a better outcome.
finally, we have to look at the trauma surgeon's responsibility beyond the operating table. Injury prevention. This moves into public health advocacy.
Clinicians have a unique perspective on injury mechanisms. They see the patterns firsthand. The source gives a perfect example of responding to a recurring mechanism. If you treat several patients who have fallen 2 to 3 meters from the same location, say a specific poorly maintained bridge, that indicates a systematic failure of infrastructure.
Like damaged safety barriers.
Exactly. And the surgeon, having witnessed the consequences, has a responsibility to engage with stakeholders, municipal authorities, politicians, manufacturers, to eliminate that mechanism or mitigate its consequences.
And prevention is also about responding to patient factors, particularly in our vulnerable elderly group.
We need unified, systemic measures to address poor bone stock. This means leadership in developing guidelines for preventative therapies.
What kind of specific preventative measures?
The aggressive prescription of bone protection therapy, like bisphosphonates, after a fragility fracture to prevent subsequent, more serious breaks. Furthermore, addressing underlying comorbidities that cause falls, like proactively referring patients for cataract surgery to correct visual impairment, is critical. The surgeon's role extends far into preventative medicine to reduce the incidence and severity of injury in the first place.
Okay, so key takeaways for prevention and planning. Preoperative planning must rigidly define Plan A, B, and C. Local protocols standardize high-risk interventions. Trend monitoring allows for early identification of evolving complications, and clinicians must actively engage in prevention.
That's a great summary.
This deep dive into Baily and Love, Chapter 26, has provided the necessary structure, anchors, and rationale for approaching the complexity of trauma. We really hope this interpretation serves as a powerful foundation for your studies.
Let's just solidify the trauma trilogy, the 3 core concepts that must anchor your understanding of the field.
Number 1, the formula. Mechanism plus patient equals injury. Always critically test the patient's story against the injuries you find, and aggressively search for hidden pathology or deception when that equation doesn't add up.
Number 2, the timeline. Time is life. The ATLS ABCD hierarchy is the non-negotiable protocol, forcing you to prioritize what kills first and ensuring assessment and response occur before irreversible physiological collapse.
And number 3, the strategy. The critical strategic choice between early total care ETC and damage control orthopedics DCO, a decision that is strictly determined by objective physiological criteria, not just the anatomical injuries.
Remember, while this discussion is designed as a foundational ready reckoner, mastery requires consulting the detailed text, understanding the nuances of the pathology, and integrating these clinical principles with your growing experience.
We covered the critical path, but let's end with a final provocative thought for you to explore as you continue your journey through surgery. The constant threat of the second hit theory and the defined physiological criteria for DCO fundamentally shift the surgeon's role. It's no longer just about deciding how to fix an injury.
In trauma, the life-saving decision often lies in deciding when not to operate. If a patient is too cold, too acidotic, or too coagulopathic, how does recognizing the absolute limits of their biological reserve transform the trauma surgeon from primarily a technical fixer to primarily a physiological manager? Think about that profound balancing act and the humility it requires as you approach your next patient.